Assalamu alaikum students, I am Dr. Ammara Sarwar and today we are going to discuss the gross anatomy of temporomandibular joint. So let's start with the topic. Temporomandibular joint is formed by the articulation of the squamous temporal bone above and by the head of mandible below. So it is located in front of the tragus of the ear and on the lateral aspect of the face. It is a modified hinge type of synovial joint and condylar variety. So there are two articular surfaces, an upper articular surface and a lower or inferior articular surface. Upper articular surface is formed by the articular tubercle or eminence, which shows convexity downwards, and posterior to that there is mandibular fossa or articular fossa to accommodate the head of the mandible, while the lower or inferior articular surface is formed by the head of the mandible. Articular surfaces of the bones are covered by fibrocartilage, and these two bony articular surfaces are separated by an intervening articular disc. Now here in this sagittal section, you can see the two articulating surfaces of the temporomandibular joint. Here the articular tubercle and the articular or mandibular fossa, while this is the head of the mandible. Now these bony surfaces are covered by the fibrocartilage, and there is an interarticular disc in between these two articular surfaces. Now this articular disc is attached at its periphery to the fibrous capsule of the temporomandibular joint and is divide the joint cavity into two compartments. A superior compartment which lies between the articular tubercle and the mandibular fossa of the temporal bone and the articular disc. This is also called the meniscotemporal compartment, and here the gliding or protraction and retraction occurs, while the inferior compartment lies between the interarticular disc and the head of the mandible, and this is also called the meniscomandibular compartment. Here the elevation and depression as well as the rotatory movements occur. Ligaments related to the temporomandibular joint. There are two primary and two accessory ligaments. Primary ligaments are the fibrous capsule and the lateral temporomandibular ligament, while the accessory ligaments are the stylomandibular and sphenomandibular ligament, and we will discuss them one by one. First of all, the fibrous capsule. It surrounds the temporomandibular joint and is attached above to the articular tubercle, margins of the mandibular fossa and the squamotympanic fissure, while below it is attached to the neck of the mandible. Above the articular disc, it is loose, while below the articular disc, it is tight. And the capsule is lined by the synovial membrane. Now, the lateral temporomandibular ligament, it is attached above to the articular tubercle and below to the posterolateral aspect of neck of mandible. It reinforces and strengthens the lateral part of the capsular ligament and acts to prevent posterior dislocation of the joint and fracture of tympanic plate when a severe blow falls on a chin. Two accessory ligaments are the sphenomandibular ligament and the stylomandibular ligaments. So the sphenomandibular ligament attached superiorly to the spine of sphenoid and inferiorly to the lingula of the mandibular foramen. Now here you can see in this diagram that the sphenomandibular ligament is attached superiorly to the spine of sphenoid, and it is attached below to the lingula of the mandibular foramen. Lingula is the bony projection at the mandibular foramen on the medial aspect of the ramus of mandible. Sphenomandibular ligament acts as a check ligament for the movements of the mandible at the temporomandibular joint. Now the next is the stylomandibular ligament. It is attached above to the styloid process and below to the angle and adjacent part of the posterior border of the ramus of mandible. Here you can see the stylomandibular ligament. Superiorly it is attached to the styloid process, while inferiorly it is attached to the angle and the adjacent part of the posterior border of ramus of mandible. Stylomandibular ligament basically is a thickened part of deep cervical fascia which separates the parotid and submandibular salivary glands. These are some important relations of the temporomandibular joint. Laterally, there is skin, fascia, and parotid gland. Here you can see the parotid gland, while skin and fascia has removed. Medially, there is spine of sphenoid along with sphenomandibular ligament, auriculotemporal nerve, maxillary vessels, and middle meningeal artery. These relations you can see in this diagram, that there is spine of sphenoid along with the sphenomandibular ligament, auriculotemporal nerve, maxillary artery along with vein, and middle meningeal artery. While anteriorly, lateral pterygoid muscle and mesenteric nerve and artery. Here you can see anterior to the temporomandibular joint there is lateral pterygoid muscle, and along with mesenteric nerve and vessels which supply the masseter muscle, and you all know that masseter muscle is attached on the lateral aspect of the ramus of mandible. While posteriorly, temporomandibular joint is related to the tympanic plate. Here you can see posteriorly the tympanic plate, and the parotid gland separates the temporomandibular joint from the external auditory meatus, and there is also superficial temporal vessels. Blood supply of the temporomandibular joint. Branches from the superficial temporal artery and maxillary artery supply the temporomandibular joint, and mainly the deep auricular and anterior tympanic branches of the maxillary artery supply the joint. While the venous drainage, veins drain through the superficial temporal and maxillary veins. Temporomandibular joint is supplied by the articular branches of the auriculotemporal nerve and the mesenteric nerve.
Now, movements of temporomandibular joint. These movements are elevation, depression, protrusion, retrusion, and lateral movements. Muscles responsible for these movements are muscles of mastication and suprahyoid and infrahyoid muscles. मसल्स ऑफ मेस्टिकेशन आपके साथ डिटेल्ड डिस्कस किए जा चुके हैं, और सुप्राहायोइड और इंफ्राहायोइड मसल्स जो हैं वो आपके अगले लेक्चर्स में कवर हो जाएंगे. सो लेट्स डिस्कस दीज मूवमेंट्स. एलिवेशन इज क्लोजर ऑफ माउथ, इज द एक्शन ऑफ टेम्पोरालिस, masseter and medial pterygoid. Depression is opening of mouth. Mainly it is caused by lateral pterygoid, suprahyoid and infrahyoid muscles. Protrusion, it is caused by lateral pterygoid, masseter and medial pterygoid. Retrusion, is the action of temporalis. Its posterior oblique and near horizontal fibers cause retraction and partly by masseter. Lateral movements, which are grinding and chewing movements, is the action of temporalis of.
So we have discussed the movements that occur at the temporomandibular joint along with the muscles that are responsible for these movements. Now we briefly discuss the mechanism of each movement, that how these movements occur at the temporomandibular joint. So first of all, the protrusion of the mandible. In protrusion of the mandible, the articular disc along with the head of the mandible pulled forward into the articular onto the articular tubercle. Now here is the articular tubercle and this is the mandibular or articular fossa. In protrusion, this articular disc along with the head of the mandible pulled forward, and this results in the protrusion of the mandible, and protrusion occurs in the superior compartment of the joint cavity, while the retraction of the mandible occurs when this articular disc along with the head of the mandible are pulled backwards into the mandibular fossa, and retraction is also takes place in the superior compartment of the joint cavity. Now the depression of the mandible. Initially, as the mouth is opened, the head of the mandible rotates on the under surface of the articular disc around a horizontal axis. To prevent the angle of the jaw impinging unnecessarily on the parotid gland and the sternocleidomastoid muscle, the mandible is pulled forward. So this is accomplished by the contraction of the lateral pterygoid muscle, which pulls forward the neck of the mandible and the articular disc so that the later moves onto the articular tubercle. So first step in the depression of the mandible is the rotation of the head of mandible under surface of the articular disc around a horizontal axis. So this movement, this rotatory movement occur in the inferior compartment of the joint cavity, and this is followed by the forward pull of the articular disc along with the head of the mandible by the contraction of the lateral pterygoid muscle. Now this is a very important question and frequently asked question, that what is the role of the lateral pterygoid muscle in depression of the mandible. So here is the answer, that the rotatory movement, initial rotatory movement of the head of the mandible, which occurs under surface of the articular disc, is followed by the forward pull of articular disc along with the head of the mandible, and this movement ends when the articular disc and the head of the mandible lie under the articular tubercle. If this goes beyond, then the dislocation of the temporomandibular joint occurs. Elevation of the mandible is the reversal of the movements as in the depression of the mandible. First, the head of the mandible and the disc move backward, and then the head rotates on the lower surface of the disc. Now, the lateral chewing movements or side to side grinding movements are accomplished by the alternately protruding and retracting the mandible on each side. A very important clinical correlate is the anterior dislocation of the temporomandibular joint. So dislocation sometimes occur when the mandible is depressed, and in this movement the head of the mandible along with the articular disc moves forward to reach the summit of the articular tubercle, and in this position joint is unstable and a minor blow to a chin or yawning or taking a large bite cause the head of the mandible slips out of the mandibular fossa and is pulled anteriorly. So this is the anterior dislocation of the temporomandibular joint and the patient becomes unable to close their mouth. The facial and auriculotemporal nerves run close to the joint and can be damaged if the injury is high energy. Reduction of the dislocation is easily achieved by pressing the gloved thumbs downwards on the lower molar teeth and pushing the jaw backwards. The downward pressure overcomes the tension of the temporalis and masseter muscle, and the backward pressure overcomes the spasm of the lateral pterygoid muscles. So, this is all about the temporomandibular joint. Thank you so much.